Here is my clinical case study presentation that was based on the assessments and interventions that were completed in the clinic at the Georgian College Oral Health Clinic with my client. So here, looking at the health and dental histories as well as the social histories, my client, it was found that my client presented with a variety of health and dental conditions that would influence my client's oral health. My client had colon cancer about 30 years ago, which has since been treated and reported smoking a pack of cigarettes daily for 40 to 45 years, but has since quit smoking for about 10 years. Regarding my client's medication summary, my client is taking irbesartan, which is an antihypertensive medication in tablet form to manage his hypertension. During the initial assessment of the client's vital signs, my client's blood pressure presented as 153/90 when using the automated blood pressure cuff. According to the recommendations set out by the CDHO regarding the blood pressure, it required myself to check the blood pressure after 5 minutes and continue with dental hygiene procedures and care as required, while ensuring to provide my client with a written copy of their blood pressure readings and refer them to their physician to monitor their blood pressure. Due to my client taking the irbesartan, one of the dental hygiene considerations that I needed to consider was client positioning, as this medication can induce orthostatic hypertension if the client experiences a sudden change in shift in position. One of my client's chief complaints was that he was unhappy with the appearance of his teeth due to the mobility and occlusal dysfunction, which influenced chewing and eating. Due to the extent of the masticatory dysfunction and mobility, it was suspected that the client may not be able to eat food adequately and might be lacking some of the essential nutrients that are required for periodontal and oral health. So here again, you can see the medications that my client is taking. So the irbesartan, which is an angiotensin II receptor blocker or an antihypertensive medication. And one of the dental considerations, as I explained, is that the client may experience orthostatic hypotension. So it is important to consider sudden position changes. My client is also taking an omega-3, which is a nutritional supplement that may influence gingival bleeding and prolong bleeding time, resulting in a slower clotting time. And then as well, the vitamin C, which is a nutritional supplement, and there are no oral considerations to consider with that as well. During the extra-oral assessment, clicking and popping of the TMJ joint was evident bilaterally without the presence of pain or tenderness. It is understood that most symptoms of the TMJ disorders originate from the muscles which is supporting the joint and not from the joint itself. During the extra-oral assessment as well, a lobulated sessile papule or fibroma on the anterior dorsal surface of the tongue that measured to be 5 millimeters by 7 millimeters on the right and 3 millimeters by 2 millimeters on the left of the midline. This lesion was suspected to be a possible irritation fibroma due to the chronic irritation, and it presented to be pink in color, matching the color of the adjacent tissues. It presented as round and oval and was approximately 1 centimeter in size, which matches the description of an irritation fibroma. With the dental assessment, my client presented with generalized severe attrition and fractions attributed to an advanced bruxism habit, and this client also presented with a fracture on tooth 2.7 at the cervical third of the tooth root, and a class 1 mobility on tooth 2.6 and 2.8 with a class 2 mobility on tooth 4.2. The client's caries risk was extreme due to the diagnosed caries showing penetration into dentin, saliva-reducing factors, as well as irregular oral hygiene care. Looking at the periodontal assessment of this client, the client was staged and graded as generalized periodontitis, stage 4, grade C, and the staging and grading of this client's dental hygiene periodontal diagnosis was based on the class 4 furcation involvement on teeth 1.7 buccal, 2.6 buccal, and 2.8 buccal, with generalized 50% horizontal radiographic bone loss, with 90% horizontal radiographic bone loss localized to the 2.6 and to the 2.8. The maximal probing depths interproximally presented as 8 millimeters in one site, and the highest interproximal clinical attachment level was 13. Due to these factors, the stage of this client's periodontal condition presented to be stage 4 relating to the cal greater than 5 millimeters, bone loss extending to the middle third of the root and beyond, and more than 5 teeth lost due to periodontitis, masticatory dysfunctions, mobilities, and furcation involvement. The grading of this client's periodontal condition was deemed grade C due to the percentage of bone loss over age being 1.12, indicating that this client is at a rapid rate of progression. The goal relating to the periodontal statement, again, was to create an oral environment that supported periodontal health by the end of care through education and debridement. And then here you can just see the periodontal chart. So as you can see, interproximally, mainly we are seeing kind of those fours and fives in the posterior region. With on tooth 1-7 lingual, you can see at the mesial interproximal surface there is an 8 mm pocket, and the highest interdental PAL presented to be 13 and 12. So there were some higher numbers there, which again presented at that stage 4 grade C periodontitis. With regards to the gingival characteristics, these were also indicative of the periodontal diagnosis, as the color was generalized dark pink, generalized rounded marginal gingiva, generalized blunted papilla, with 36% moderate bleeding on probing, and mucogingival involvement present on the tooth number 3-1, 3-2, 3-3, 3-4, 3-5, 4-5, and 2-3. The plaque-free score was 51%, and my client presented with generalized supra and subgingival calculus deposits with extrinsic staining scattered interproximally, which can contribute to the findings of the periodontal classification. And overall, this client's diet was well balanced and was meeting the recommendations that were set out by Canada's Food Guide. Here, looking at the radiographs, so regarding the radiographic interpretation, there were suspected proximal caries on the 3-3 distal occlusal, 3-2 mesial, 2-8 mesial distal, 3-5 distal, and 3-4 distal, with suspected root caries on the 3-5 distal. As you can see as well on the radiograph, on the 2-7, it was a fracture at the cervical third of the root. You can see as well a crater on the 3-5 occlusal surface. You can also see the periapical lesion on the 3-1 and an intrareticular lesion on the 2-6. As we mentioned before, there was generally 50% horizontal bone loss with localized 90% horizontal bone loss on tooth 2-6 and 2-8, with localized vertical bone loss on tooth 4-4. As well, you can see the furcation involvement on tooth 2-6 and 2-8. And here as well, you can see the radiographs that were taken in 2019. So there was really no significant changes since the last time that the client was in the clinic regarding bone levels. And everything kind of remained static and didn't increase in bone loss at all, which is really good to see. And then here you can see the panoramic radiograph as well, just kind of seeing a full picture of all the teeth together. And here's again the radiographic interpretation. Looking at the oral health indices, so again, my client had total number of teeth was 21. There was total plaque score of 43, which put his plaque-free score at 51%. The number of bleeding points presented as 45, putting the bleeding index at 36%, which is a moderate bleeding on probing percentage. And then the periodontal summary score, there were probing depths that were greater than 3 millimeters was 23, and then probing depths that were greater than 6 millimeters was 2. Looking at the risks assessments and barriers, so the client is retired and financials are a consideration that prevents this client from receiving dental care in a private practice. It was also important when explaining the dental hygiene care plan with this client that due to the extent of his periodontal condition and diagnosed caries, the non-surgical periodontal therapy that I was providing at the college would not necessarily be sufficient in bringing my client back to periodontal health and achieving a state of optimal oral health. My client also explained that he did have arthritis in his fingers, which prevented him from being able to grasp his fist. So when educating my client on oral self-care instruction, I ensured to address this barrier through educating my client on using a tennis ball on the handle of the toothbrush to be able to adequately brush their teeth. Other risk factors as well and barriers. So the class 4 furcations act as a biofilm retentive factor. With the moderate and supra and subgingival calculus deposits, they must be professionally removed, and due to the financial barrier of this client, he wasn't necessarily coming in for his 3-month supportive periodontal therapy interval. So that puts him at a higher risk for further progression of bone loss. The periodontal prognosis, so following the 4 to 6 week reevaluation of care, it can be determined that due to a variety of factors, my client's periodontal prognosis is low. There was a decrease in plaque-free score from 51% to 50%, minimal reduction in probing depths in localized areas, and minimal reduction in bleeding on probing. Relating to the extent of my client's periodontal condition, it was also determined that through non-surgical periodontal therapy and debridement in the clinical setting, it would not be able to remove calculus deposits effectively and safely from 8 mm pockets, and with a periodontal referral acknowledgement letter that was signed by the client. Without the client receiving treatment, the client's periodontal condition would likely continue to progress and further clinical attachment loss would be seen clinically and radiographically. So again, looking at the stage 1 initial therapy, the main goal relating to my client's periodontal condition was to create an oral environment that supports periodontal health by the end of care through education and providement. Providing my client with education on the periodontitis disease process while placing an emphasis on the importance of being able to have the client identify their own risk factors for periodontitis, such as xerostomia, biofilm retentive factors, and pharmacological factors. And as well, although the client's diet was well balanced due to the high caries risk and poor periodontal prognosis, nutritional counseling was included in the care plan to allow for the client to be aware of the cariogenic foods in their diet, while also providing recommendations for specific foods and nutrients that support periodontal health and oral health. As well, we did the topical fluoride varnish to, again, decrease my client's caries risk, and a 3-month supportive periodontal therapy interval was recommended. So again, the goals for the initial therapy were to eliminate inflammation, decrease the bleeding, reduce periodontal pockets, and regenerate some of the tissue that were lost. With regards to stage 2 surgical therapy, some options that could be recommended for this client would be open flap debridement. So this could be beneficial therapy option for this client as it is used to improve the overall efficacy of subgingival debridement through gaining access to root surfaces, root concavities, and furcation sites in periodontal pockets with root resorption. Another option could be osseous resective surgery, which can be used to correct osseous deformities in the alveolar bone, and the main goal of this approach is to eliminate deep periodontal pockets through apically displacing the gingival margin, which would allow for easy cleaning of this client and the dental professional. Multiple extractions would also be recommended, such as the sheet numbers 35, 32, 45, 31, 26, 27, and 28. In the duration of the treatment at the college, the client did not have these teeth extracted, but it was still discussed, and the possible referral for dentures as a means of prosthesis was also discussed. The goal for the surgical periodontal therapy would be to eliminate active infection, reduce periodontal pockets to a level that is more cleansable by the client and more cleansable by the dental professional, and as well to replace the damaged or destroyed periodontium. Looking at the stage 3 restorative therapy, so again, due to the extent of my client's subtraction, the teeth were susceptible to fracturing, so composite resin restorative material would be a recommendation due to the client's aesthetics, and it can be applied to class 5 cervical abrasions and abfractions, and it is also able to be used in high-stress posterior teeth. So again, to restore this client's biological sound and functional dentition, it would be advised to have teeth number 35, 32, 45, 31, 26, 27, and 8 extracted and place partial maxillary and mandibular dentures to return the client's occlusion to a functional state. And then looking at the part 4, this periodontal supportive therapy. So it was recommended to have this client in for 3-month supportive periodontal therapy interval because seeing a periodontist for surgical options would best support periodontal health and achieve optimal oral health. The recommendation for a 3-month supportive periodontal therapy interval was due to a low periodontal prognosis and the fact that the client has deep periodontal pockets, moderate bleeding on probing, localized 90% horizontal bone loss, and a minimal decrease in bleeding on probing and probing depth following reevaluation. The recommendation for a referral was made for this client to visit a periodontist for his periodontitis, and a referral was made to a dentist for this client to have multiple extractions and restorations placed. So again, here you can see the 4 to 6 week reevaluation. So probing depths were reassessed in areas where there were greater than 5 mm pockets interproximally. So for the most part, the probing depths either stayed the same, there was a slight reduction in some of them and a slight increase in some of them. So again, that places this client at that low periodontal prognosis. And so again, here you can see the total number of teeth, again, was 21. The total plaque score after the reevaluation was 40, placing the plaque-free score at 52%. So we got an increase in 1% since the initial evaluation. And then we reprobed the teeth number 17 lingual, 26 buccal lingual, 33 buccal lingual, and the 44 buccal. So that was my clinical case study presentation, and if you have any questions, please feel free to leave them below. Thank you so much.